Welcome to the Royal College of Nursing. I'm Sheila Sobrani. I'm the Royal College of Nursing President. This event is part of an exhibition series developed by the RCN Library and Archive Service with the History of Nursing Forum and Royal College of Nursing members. The COVID-19 pandemic has been declared officially over, but the series will help us to continue learning from the experience of nursing staff who lived through the months and years at the eye of the storm. Many of our loved ones at work and at home continue to suffer the effects of the pandemic psychologically, physically, financially, and emotionally. We know that nursing staff from Black and global majority backgrounds were not adequately protected during the pandemic, and we must do all we can to tackle racial disparities across society. That's why I'm especially pleased to welcome the BLACK FRONTLINE to the RCN. The BLACK FRONTLINE is the largest oral history project of global Black doctors and nurses. It was founded by the Armah Institute of Emotional Justice and co-directed with COVID Black, with funding from the Skoll Foundation. Framed through 300 narratives of doctors and nurses recorded during the COVID-19 pandemic across the United States, the United Kingdom, and Ghana. The BLACK FRONTLINE is a bridge that connects, informs, engages, and transforms. Tonight's event will focus on the nursing stories from the project. With no further ado, I'd like to welcome the founder of the BLACK FRONTLINE, Esther Armah, to introduce the audio exhibit.
Hello. So good afternoon, good evening, wherever you're joining us. If you're in the chat and online, let us know where in the world, where in the country you are joining us online. And to Sheila's point, we know that folks may have questions, but also comments and thoughts as they listen, and we would love to hear from you. Just to let you know what I'm going to do, I'm going to introduce the project and walk you through the creation of it, the building of it, because this was something that was a structure built from the ground up with a global team, and although I'm described as the founder, it really is the definition of a global team required to actually build this thing and put it up on its feet. And we'll hear some of these extraordinary stories, and then there'll be a panel discussion with two extraordinary Black women, both engaged with the project and doing work within healthcare. And so I'll get to that a bit later. But I'm going to start with making sure that I can see. That's a good beginning. Okay, so I'm going to start with this presentation. Question for you. What happens when you go behind the mask and frame a pandemic through the stories of global Black nurses in 3 countries, the United Kingdom, the United States, and Ghana? The story of the BLACK FRONTLINE begins in my home, like so many millions of us in March and April of 2020. Lockdown, isolation, fear, loss. We know that it's a global pandemic. There are varying messaging. There's varying messaging around what exactly it is. The politically partisan perspectives are not helping with the information. They're just elevating a sense of fear for so many different people. So I'm sitting at home, myself described as a global Black chick. And by that I mean I was born in London. London is the city of my birth. Went to school here. I have family here. And then I lived and worked in New York for almost a decade before then moving to Ghana. And so those 3 cities, London, New York, and Accra in Ghana, are 3 places where I have an engaged community. So in March and April of 2020, I was beginning to get messages, given that the only way for us to all communicate was online. I was getting messages and stories and then hearing stories from both healthcare workers and within my own community about what people were going through. And the shared trauma and isolation, but also the powerlessness, created the beginnings of what would become the Black Frontline. I got in contact with a phenomenal Black woman called Dr. Kim Gallen, who is the founder of and director of COVID Black and an associate professor at Brown University. And the two of us began to work on this specific project that would become the Black Frontline. So, we're inviting you into this world. It's about loss and courage, sacrifice, community, trauma, and the colliding realities of structural racism, inequality, health disparities, and the ways that those things manifest in community, society, and nation. So I've talked to you a little bit about how it begins. It's important to acknowledge that the project is made possible with funding from both the Skoll Foundation and the Mellon Foundation. During the pandemic, lots of philanthropic institutions pivoted and worked to put funding into spaces they might not otherwise have funded in order to ensure engagement and stories from communities that are traditionally marginalized. And the Armah Institute of Emotional Justice, my organization, was one of the beneficiaries of that pivot. And so we are the founding organization, and it is co-directed, as I said, with Dr. Gallen from COVID Black. And so the methods, I'm going to talk about the methods, the process, the stories, and then the website. So it's specifically about care-based storytelling. In the world of emotional justice, and the Black Frontline is an emotional justice project that engages Black digital humanities. And emotional justice is a racial healing roadmap, and we develop racial healing resources, engaging projects and training and thought leadership. So this project is a racial healing resource. It's about how do you engage storytelling as a strategy to transform systems, in this case, healthcare. So full disclosure, I am neither a nurse nor a doctor. I don't work in healthcare. With emotional justice, it's really about the storytelling as the strategy for systemic change and using the structural foundation of emotional justice in partnership with other methodologies in order to build a structure. And in this case, care-based storytelling was really crucial. Why? So often, the stories of Black people are carelessly handled. People are reckless with their stories. There's a lack of understanding of what it costs to even tell them. And there's too little thought about why and how important they are. So emotional justice and the approach was about transforming that. It was very much about the combination of these four things. The levels of loss were devastating. The death toll was escalating at levels that had everybody breathless and terrified. There was elevating and escalating levels of trauma. And then there was this notion of, can you create power in terms of building shared community? So the method, the theory, and the approach. I've said at Foundation, this is an emotional justice project that engages Black digital humanities. The Armah Institute of Emotional Justice, we are the implementation home of this racial healing roadmap, emotional justice, developing these racial healing resources through projects, of which this is our flagship COVID project. We also engaged with the Columbia Center for Oral History Research and Insight. That was in order to gain an understanding of the highest level of quality oral history, the methodology in developing it, the kind of research that was being done, the nature of questions, the approach. All of those things were important to research in beginning to build and develop what would eventually be the Black Frontline. COVID Black was co-director for the project, and as an organization looking at the intersection of health, data, and Black digital humanities, the mixed methodology of emotional justice, journalism, I come to this work as a journalist. That was my former profession. Storytelling, foundational point of emotional justice, Black digital humanities, and data. The founding connective piece is the compassion and the care, specifically connected to Blackness. And so it's COVID. There's no physical way to engage with anybody in person at all. So crucial for the digital home of the stories is their story. So their story is an online platform that is literally about people gathering oral histories, often family, but now academic institutions and different organizations. This is the wonderful Zach, who was extraordinary in working with us to develop and build, Zach Ellis, who developed and built the Black Frontline, and their story was where the interviews were done, they were held, and they're gathered and still are now. All of the stories, and there are more than 300 stories altogether of Black nurses and Black doctors from across the UK and the US and Ghana, are held on one site called the Black Frontline that was designed by this organization, included. Renee Payne is the founder of that. She's an extraordinary creator, visual creator, and really put so much love and care into the building of the website. So those were the elements that were really important in building the foundation of building the structure that was the Black Frontline. But it's really a project that's all about people. And the question was bringing different kinds of people together. So for example, how do you ensure you have the pedigree of Harvard, but you're engaging grassroots, activist-oriented, younger healthcare folks who are not in those spaces and are in those rooms, but they're doing really important work on the ground. And so the advisory board really was about bringing together a range of generations. We knew that it was going to be global and from different expertise. So on my far left-hand side, that's the US advisory board. That's Dr. Alden Landry, who is the assistant dean at the Office for Diversity, Inclusion, and Community Partnership at Harvard University. Sorry, it's Aidan Landry, not Alden. Dr. Ijeoma Indomin Opara, who's an assistant professor at Wayne University, and a phenomenal activist-oriented doctor. So putting those two people together was crucial. In the UK, we had Dr. Emezie Okorocha, who's the founder and director of the African Caribbean Medical Association, and Professor Tolula Oni, who is the Medical Research Council at the University of Cambridge. Again, the pedigree of Cambridge University and the grassroots activism of the African Caribbean Medical Association. And then in Ghana, we had a very dynamic young doctor called Dr. Yao Bediako, founder and director of Yamachi Biotech, who has a stunning major leadership team of all Black women in Ghana. And then the very high-profile Dr. Ernest York, who is the chairman of the Ghana Medical Association in Greater Accra. So the guidance and expertise and wisdom of this collective group of people helped shape the project, and conversations with them were really helpful in understanding what was happening in terms of the world of those working in healthcare as opposed to us on the receiving end of that healthcare. That was very crucial. The advisory council was about helping us understand the landscape of healthcare. Then we needed those who were actually going to gather the narrative on the ground, do the work of actually recruiting, engaging, and interviewing these hundreds and hundreds of Black doctors and nurses. So again, left to right, I'm going to say their names and introduce them. We had Joan Mukokosi and Romain Morgan. They were in the United States. Carol Cooper and Abigail Bernard, who were here in the UK, and Sena Afadu Danfal and Amma Kramper, who were in Ghana. I think what's important to recognize, because two things. One, of course, we're in COVID. We're dealing with levels of loss and trauma. So part of what was important in our approach and our methodology was developing a culture of care in even the gathering of the stories. So we would have these weekly meetings, checking in with everybody who's actually story gathering, to hear from them how the gathering process was going. It was incredibly challenging at points because, of course, the Black healthcare workers are on the front line and they are literally dodging multiple bullets through the pandemic, through the nature of systemic racism in healthcare, through the terror and fear of not understanding fully what COVID was, through the absence of real protection. So the combination of all of those things, and then you have a project inviting people. We knew people wanted to tell their stories. There were two issues that were major. One was the importance of a safe space to fully share what they were experiencing. But second, recognizing that the nature of power structures means there was risk in telling your story. It isn't as if the telling of your story in its totality, in its fullness, was necessarily going to be rewarded. So that part of our approach meant anonymity was crucial because backlash was more than a possibility. There were cases that demonstrated what happened when Black nurses shared their stories and chose to fight back against a system that was disrespecting and negating their humanity. So I can't say enough good things about the narrative gatherers and the amount of work it took. It took us, it's taken almost 2.5 years to put the entire project together. The narrative gatherers worked, I think, for almost a year to bring all those stories, more than 300, recruit them, record them, engage them, listen to those interviewees, and hear just what they had gone through. So collecting the stories required its own approach. So one of the things that we did was develop the Black Frontline manual. Really, that was the work Dr. Gallen did in developing and building the manual. So what we wanted to do, working across 3 different territories, was develop a standardized approach to gathering the information. So we wanted to ensure everybody's being asked the same questions, but that also we wanted to acknowledge the specificity of Blackness in different geographical locations. So to be Black in Britain is not the same as to be Black in America, is to be different than to be Black in Ghana. So how do we ensure that we are honoring the specifics of the Blackness of each of the geographical regions we're engaging, while developing a common foundation that can allow for the project to be engaged and for the public to engage the project. So the TBF manual was our instruction guide to how we were going to ask the questions, what the approach was going to be. As I said, I come to this work as a journalist, so asking questions is part of the work that I have done. But this is not a story. These are people's lives that they are navigating. And so deciding on not just what questions to ask, but how to ask them, the approach to take, was all of that detail was part of developing this manual. That also gave all the narrative gatherers the foundation of the project, the fact that it was mixed methodology, and that everybody needed to be asking the same questions. What was revealing and interesting was the recruitment process, and during the panel, because we're blessed that one of our site managers from the UK is here. She will talk more about the recruitment process and its challenges, but each site required something different in order to engage people. So in the US, it was very much social media and online. LinkedIn, WhatsApp, Twitter was instrumental. In the UK, email, we did a lot of Zooms, reaching out to specific organizations, doing introductions, sharing with them the vision and the mission of the story. And, the UK was both hostile in some ways, challenging, difficult. I really want to do a special thank you to Sheila Sobrani, your RCN president, who really was one of the very, very first people who came on board in a very action-oriented way. Spoke specifically about the importance of the project, gave us some very important context about what was happening in healthcare at the time and some of the challenges that we may face, and that context was crucial in establishing a way forward that could actually be successful. And then equally importantly, gave us a really good starting point of names and people to call and people to engage so that we could actually get the ball rolling. And I think the example of that action, I think, is part of how we need to move forward in thinking about the next stages of COVID. Not what are the things that we can say to soothe the trauma, but what are the things we must do to deal with the legacy of an ongoing COVID reality. So we thank Sheila for that. And then the questions. Everybody was asked the exact same 8 questions. And Kim and I spent a lot of time going through them, figuring them out, kicking some out, putting others in, because we were specifically thinking about 2 things. One, emotional justice is about storytelling as a strategy for systemic change. So it's not simply storytelling for the sake of storytelling. It is developing a strategy to make systemic change. So in other words, how might this project help shape the future of healthcare? How might it contribute to challenging the kinds of systemic racism and health disparities that destroy experiences and people's work lives and people who are on the receiving end of that treatment? And how might this project contribute to that? So these were the questions. They're all listed here, and they're listed on the site. And I'm not going to go through every single one of them, but I'll give you the theme. So we were dealing with issues of fear and loss, how people got through, what helped them, how did they deal with the kind of loss that they had to navigate, what kind of support and protection did they have. We asked them to share their experiences relating to discrimination. How do they feel about the public health information campaign on vaccination? We asked them, given their experiences, what kind of important changes they would like to see to make their job safer, to help people better serve patients, and to end discrimination in the world of healthcare. And a huge question that really gave us a lot of richness was, what would you like the public and the world to understand about being a Black nurse or a Black doctor during the COVID-19 pandemic? So those areas were the areas that we were looking at, and everybody got asked, all 300 plus people got asked the same questions. And so all of the questions are on the Black Frontline website, and we want you to have a chance to hear some of what Black nurses were navigating and listening to. So what you're about to listen to is about a 15, 16-minute excerpt of stories of different Black nurses from across the UK, across the US, and Ghana, sharing different experiences they had. And so these are some of the stories that are behind the mask from the Black Frontlines, Black nurses. While we're waiting for them, we want to definitely share a couple of thank yous in terms of the nurses, the Black nurses who really went out on a limb. Everybody's story, every single Black nurse that spoke to us was taking a risk of some kind and was making taking a really important step on, one, the importance of sharing their story. For some people it was healing, for some people it was triggering, for some people it was empowering, for some people it was enraging. I definitely want to honor Monica Harmon, who is the president of Southeastern Pennsylvania Black Nurses Association, who was incredibly helpful in us getting nurses from that part of the world. There was a nurse in Ghana who is part of the stories, and so I can't mention her name because those who contributed to are anonymous, but who was absolutely instrumental in ensuring that we could get nurses in Ghana to speak, who both wanted to speak and also feared speaking. And that combination of the desire to speak and the fear of what will happen if you do was such a crucial back and forth that we navigating the entire time. So I'm waiting for a thumbs up before we can play. Okay, so now let's take a listen to some of these stories and these excerpts.
The most frightening aspect of this COVID-19 pandemic is the devastation of loss. We saw in the first wave, within 10 days of getting sick, people would just die and there was nothing you could do. The x-rays, no amount of treatment, no amount of turning, no amount of oxygen was helping anyone, and it was just obliterating life. And it was something that was absolutely frightening. I felt I was very more antisocial because we didn't know how this virus was spreading further and beyond. You knew that people got flu-like symptoms and then they just went downhill from there. And the devastation my colleagues faced, friends of mine who are nurses, they were seeing the failures within healthcare because their own family members were dying and they weren't able to say proper goodbyes, and they had a couple of weeks and then they'll go back to work and deal with the same devastation that was just spreading wide and far.
You can just kind of look and tell that someone was slowly dying. You know, the patients that you had known for years and they were doing okay and they were thriving, and now after COVID, they're just completely wiped out to the point where either this patient will need G2 care and sent to the hospital or they need hospice care at 90, 80 years old. And having hard discussions with the family members about which road to take for this 80, 90-year-old person that now can't do anything for themselves, struggling to breathe. Do you go hospice? Do you go full code and send them out to the hospital? And yeah, I've had a lot of conversations like that during COVID in the facility.
I felt I was in danger. Every day when I get to work, I feel that, look, anything can happen when I'm entering this ward. And so this is my battlefield. Lord, I commit myself to you. Take me through and bring me out when my shift is done. One moment that I will never forget was the first moment that I had to suction someone who was COVID positive. And that was the initial stages that things were not clear. And so you know the mode of transmission. And this time around, you've gone so close to the patient just to help the patient breathe. So you have to suction something that will produce aerosol, so predisposing you to actually contacting the virus. And that moment, I felt that I was closer to the virus than any other moment.
I can remember exactly where I was when the word started to come out that the virus was getting closer and closer to where I live. Initially, I had this comfort of, okay, well, it's not near me in this moment, that I'm still okay right now. But I knew at the time, though, my husband worked in, and I said, you can't go back into your office, because we just didn't know what this virus would bring or what it would do.
As somebody who had been a nurse at this point for 15 years, I'm what a lot of people would consider an expert. I have a PhD. I have 2 master's degrees. I teach this stuff. I'm a college professor, and I did not expect to feel like a novice all over again on a unit that I was very used to working on for the past 15 years.
I only ride on hope and faith, but in actual fact, I haven't gotten through this whole period. It's a difficult thing to get over, because the moment you get into work, there's a difficult situation you have to solve with patients' admissions, having to reject admissions because there are no beds. It's happening all the time. So you even get more mentally fatigued than physically fatigued. So if I say I'm getting over this situation, I won't be telling the truth. So we go to work hoping that things will get better.
I dealt with the loss by finding solace and comfort in knowing that I did my very best and I gave each patient my very best given the circumstances. And whenever I had the opportunity to be a surrogate family member of a dying patient or step in just to hold their hand to make sure that they didn't die alone, whatever thing I can do to give them some sort of comfort in their last few moments or days, I did try to do that as much as I can.
This was my first leadership role, and I was so scared because I didn't know how to lead in this kind of scenario. I had a young lady ring into the bed management team, and she said, look, I'm so scared. I don't want to go and support this patient in hospital. I'm scared that I will die. I had to have this really difficult conversation with this person and say, I'm really sorry. I know I'm scared too. I think we're all scared because we don't know what this is, but you have to go and be with that patient. I felt it with such a heavy heart because am I sending someone into the fire? Am I sending someone to die?
I've had managers in the past who I was a deputy manager and they didn't want me in that post, and they made it very clear. My interview took twice as long as anybody else's interview, even though I got the job. Shaking my hand, she said, like, don't stab me. I was like, I don't understand why that would even be a thought. And I actually ended up leaving that job because of it, because we do all of this work on our mandatory training to do with ethnicity and race and making sure what we're saying is appropriate, and to then be put in the position where something like that can happen, and then having the conversation with HR and stuff like that, for that not to even go any further and, oh, we'll just move her. I think definitely conversations need to be had and stop letting things go under the carpet, because without that, people won't stop discriminating because they can get away with it. So I think making people accountable for what they're saying and what their actions are, and showing that it's just not okay.
If you're really shocked at how Black people are dealing with racism, then you really need to look at yourself and how you talk to people. How do you treat the Black people in your life? Do you have any? Because you'd be amazed. And there's a lot of things that people don't seem to understand. And the worst thing about this pandemic, it really rips open the inequalities that we face. And when I say we, I say Black people, Asian people, because as a nurse, you already see it working in the front lines, day in, day out. I'm a pediatric nurse, so I see it within the children and the families. You see it day in, day out. And suddenly this pandemic really exposed it further, to the point that the healthcare professionals like me are on lower pay. They're on the front line, whereas white people, they tend to get ahead up in the careers, and they're in the back making the decisions about how to deliver the service. And we already knew about this, as a nurse, you see it day in, day out. And the worst thing is more of us were dying. The General Medical Council, the Nursing and Midwifery Council, our governing bodies, Health Education England, NHS England, they all knew about this. And the devastation really just ripped open for the world to see. And it wasn't just the UK. We saw this happening in America. We saw this happening all around the world. People that were in poverty tend to be of migrant, darker skin, non-English speaking. When you look at Italy, you look at everywhere. And that's the thing that unites us Black people in the world, is the struggle.
You had the leaders who were all Caucasian, did not go on these COVID units to support the team. But when they see them at the front of the hospital, they're showing all their teeth, all their big smiles. Oh, we support you. Thank you for what you're doing. But none of them would dare venture onto those COVID units and support these African-American staff. But they were happy to meet them at the front of the hospital to say, good job, thank you for coming to work.
We just had to go in, get the job done, and don't complain or moan. Well, as one of the BAME nurses, I was one of those that was sent to the makeshift COVID wards very often. And very, very rarely, probably only a handful of shifts, I worked in the non-COVID area. I was constantly being put with the COVID area, while a lot of our white colleagues who weren't at high risk would be in the green areas. It just highlights the fact that even if we had the assessment done, no one took the results or the fact that we're high risk seriously. No one cared.
So because I was part of the nurse in the COVID team, when my friends heard about this, and even my family, I remember my uncle told me not to come home for like 6 months. And it was very disheartening. It was very sad, because he thought if you nurse a COVID patient, automatically you contract the condition. So these are some of the things that I faced. My friends told me not to visit. They will be there and they'll just call me a COVID nurse just because I nurse COVID patients. So these are some of the discriminations that I faced, even if I just a little cough, not relating to COVID, they take it like a World Cup. Yeah. So these are the discriminations that I faced from my family and friends.
And with the worst cases were about the stigma, because I got a lot of COVID suspected cases which turned out to be positive on my ward. And even your colleagues in different wards will actually be stigmatizing, hey, that's a COVID ward, that's a COVID ward. It was really bad.
I've had patients be surprised that I'm the nurse, or they think I'm just a janitor. I've had it with doctors, their tone, or you'll see how they'll talk to one of their own nurses or colleagues versus how they'll talk to me. And even people of color, like African. Me being a Black male, born in America versus being from Africa. There's no camaraderie unless you're of the same ethnicity. And usually I'll bring it up and tell them, and then they'll laugh and try to brush it off. But racism has been here before me, is here with me, and is going to be here after me.
So my experiences with the discrimination was among my own colleagues. They were stigmatizing us that you are COVID nurse, you are working in an infected area. So even if you are coming closer to them, they want to move away from you, or they want to sack you, go back, let's have some distance before we speak. You can't even join them at the nurses' room, because where we were working, we didn't really have a nurses' room for ourselves. So we used the general nurses' room. So even if you want to change in the nurses' room, your own colleague will tell you, no, go out, do this, go and change on the ward, don't come here, and no other stuff. So with a matter of stigmatization among our own colleagues.
I've had a Middle Eastern man, he was a physician, get in my face and yell at me because he didn't think I was moving quickly enough to set his patient up for a C-section. He felt like I wasn't moving fast enough for him. And so when I walked out of the room and down the hall to get everything started, he approached me, backed me up against a wall, and began yelling in my face. He told me that I was disrespectful and that I needed to learn from the older nurses how to treat physicians. I'm a 23-year-old Black woman who has just graduated from nursing school, not even quite a year and a half before. You're invading not only my privacy, but I'm not safe anymore. That was an instance where I felt like I was discriminated against because of my age, not only my age, but also my race and my gender. It's the intersectionality of me being a young Black woman and having to be accosted.
People have to identify their biases first and realize that they have them. My goal would be for everybody in healthcare to treat every person like they are their closest and most loved family members. I wish I knew how to situations where people are just teach people that, because I see trained nurses in my field, and the biggest thing is like no judgment. I mean, you might go into a person's home they might live in a tent. I don't know. They might live in a tent. You might have to walk over shit to get in their house. Or you might go into the biggest mansion on the other side of the island. So I think the first step is for people to have down-to-earth, really in-your-face, honest people come into organizations and help people face their biases. And I know people are going to be really surprised. Oh, I don't have biases. I'm not prejudiced. I'm not racist. I don't discriminate. But people who can really bring these things out in you in a way that is unexpected, to show people how to recognize these biases, I think that's the first step.
Speaking for myself, and I can speak for some of my colleagues, we don't have that sense of belonging where we give all our time, where we give our life, basically, because going to work, you don't know what next will happen. So I think we deserve some sense of belonging. We deserve that space to feel like I belong here. And we want everyone as well, every colleague that we work with, all the managers, all the workers, all the bosses, to also understand this and that acceptance and some invitations for us to be involved in the process, in the system that affects us is very important.
We have to invest in everybody using a model of equity, because we're not all starting from the same place. So sometimes I think we focus so much on equality and treating everyone the same, but that in itself presents problems and poses challenges. So if we're going to root out discrimination, we have to root out the sources of discrimination. All the leaders, the managers, the colleagues that discriminate, they need to be rooted out. And we have all these procedures in place to do that, the forums to do that. But are they always used? Often you see somebody's discriminated against somebody, they just get a slap on their wrist, or they get moved to another area, causing more chaos in those areas. So if we want to end discrimination, we have to address the reasons people feel discriminated, the people who work with them, the systems that allow certain people to thrive and not allow others to thrive?
What helped me was the other philosophy, which is Ubuntu Ngumuntu Ngabantu, which means I am because of others, and therefore my interconnectedness to others means that I have to have the humility and the humanness to support others if I've got the ability to do so. I think it impacted very well on the patients because that meant that by me supporting the staff, because I was a senior nurse manager, it meant that they were still able to deliver care to the patients.
There were days that, in fact, I actually felt drained, tired, because I was staying longer period at work. Sometimes you are there 24 hours before you come back home. And you actually find messages from friends, from the community saying, thank you, Antoinette, for the hard work. We understand the stress you are going through. You people are at the battlefront. Thank you. May God protect you. We are praying for you. We are supporting you. We are with you in the spirit. And those words meant a lot to me, that people actually cared for me with the stress that I was going through. They understood the pandemic and they understood what I was doing as a nurse or what health workers were doing as frontliners in fighting this COVID-19.
Being a Black nurse, I think I was proud that I could also help. At least Ghana was part of the countries that were congratulated for managing the COVID in a certain way. When this COVID news came about, including health workers, people were scared. But I think some were also willing to go to the front and do something for the country. And so I think we should be proud of the fact that we are nurses and we are contributing our quota in such cases.
My husband and my kids were my pillars. Coming home to my family was what helped me get through. I came home to no expectation. They didn't expect anything from me because they understood where I was coming from. I wasn't expected to clean, to cook, or anything. Most of the time, it was already done for me. Had it not been for that support and that understanding, I know I wouldn't have gotten through.
So those are just some of the voices from the more than 300 stories that were gathered over almost 2.5 years that make up the Black Frontline. They're all housed on a website. This is the team that built the website. I just want to say their names because they did so much hard work in creating it. Renee Payne, who is the founder and director of Included, the vision behind the Black Frontline website. Dorian Flowers, who's the president of Thinkbox 312 Inc., and Teresa Carter, who's a communications consultant, were all part of the team that built it. Those stories of family and fear and stigma and systemic racism, of struggle, of courage and community give you literally just a glimpse into what global Black nurses experienced working during the ongoing COVID-19 pandemic. Because a government declares a thing over doesn't mean that those who have worked through it, that it's over for them. And part of what the Black Frontline is also really focused on and thinks it's really important is the national healing for Black nurses, for Black healthcare workers across the UK, across the US, in Ghana. Those are the 3 territories that we did this particular project. Part of the reality, if we look at global disasters, whether it's World War I, World War II, post the disaster, there is a recognition that any kind of return or recovery must be resourced. That people don't bounce back because they're not bulls, they're humans. So they need to be assisted back to health. Just as nurses and doctors and healthcare workers literally assist people back to health. So part of what matters for the Black Frontline and part of our work in emotional justice is a call to engagement and action for the world of healthcare to institutionalize a national healing for Black nurses, for Black doctors, for Black healthcare workers. The legacy of the untreated trauma of working through COVID has not been understood, has not been articulated, but is being experienced by those who worked on the front line every single day. That their families, that last voice that you heard, a nurse talking about her family got her through. Now, how is the family and that nurse being supported to continue and become part of their, and stay within the profession? We dealt with and heard about the Great Resignation, which is organizations and people leaving their profession because the confrontation of colliding traumas of the pandemics of both racism and COVID really transformed and caused a kind of come to Jesus moment for lots and lots of people. And by come to Jesus, I mean just a moment of utter reflection and life-changing reality. And so here, theblackfrontline.org, it's the website. There are more than 300 stories on there. There's information about how the project came to be. There is an entire set of resources that offer you greater context, information, things that you can read. And equally importantly, there's a guide. And the purpose of the guide is for institutions within healthcare to engage the stories and to expand those who were involved beyond the doctors and nurses, which was the scope of this particular project. So the guide is totally free. The entire website is free. Accessing all the stories is free. It's a public access project with intention. The first draft of COVID history now centers the stories of more than 300 global Black doctors and nurses. So we can never talk about a history that excludes or omits the lived experience of Black healthcare workers, which has too often been the story post-disaster of omission and erasure of Black people. And with this pandemic and this reality, we wanted to ensure not just that the stories were told, but that they were centered, and that there is no future healthcare sector that is healthy and thriving without the kind of institutional healing that requires resource and investment. And that's part of what the Black Frontline's next steps are calling for. This is the second of our 3 launches. The first was in March at Brown University. This is the second here in the UK. We did one at Barts. This event with the Royal College of Nursing is very specifically focused on Black nurses. And then we'll do a third event in Accra in Ghana later on this year, September, October. And we will introduce this work there as well. But the call around healing and national healing, the call to recognize the depth of trauma and the need to move through that and come out the other side is really, really crucial. So thank you. That is the presentation, that's the project, and that is the sound. I now want to continue with our conversation and bring up the panel. So we're all going to do a little shift, and I'm going to come over here with my chair. So I want to invite Carol Cooper, who's the head of Equality, Diversity and Human Rights at Birmingham NHS Health Trust and the founder of Global Talent Compass, to come to the stage. Carol was also really instrumental in contextualizing the UK race, health, history and the current climate for the UK arm of gathering the stories. So welcome, Carol. Thank you. From Birmingham. And we're also going to invite Abigail Bernard. Abigail Bernard is a very experienced oral historian who really led the charge for gathering stories here in the UK and also worked on other projects with noted historian David Olusoga around issues to do with Windrush, and really is the narrative gathering superstar for the UK. So welcome ladies. Thank you so much. So I think I'll start by asking, hearing those stories, listening to the experiences of those Black nurses from different parts of the world, your feedback, your thoughts.
Well, I hope they can hear me. Well, that brought back memories, really. It brought out memories of absorbing those stories and experiences.
Can everybody hear? Is that
yeah,
nice and clear?
I hope you can hear me. That brought back memories of absorbing those stories and hearing about those experiences of those nurses. Their support system, the last narrator, the last nurse talking about the support of their family, how they got through, their coping mechanisms. That brought back some memories.
Carol?
It reminded me because sometimes we are so adept at dealing with our trauma that we don't always get the twinges from it because we have lived with it for so long. But listening to those stories brought back not just emotions, but actually a physical feeling of trepidation. And it, sometimes living with racism causes a hypervigilance. And it brought my hypervigilance to the fore. It never actually goes away, but I became more conscious of it listening to those stories because it was a real collision course at that time. Dealing with COVID, dealing with racism, George Floyd also happening in the middle of that. It felt like there was a massive explosion that took place, and so it does. I imagine, I've never been to war, but I imagine that people who have fought in wars and then hear about it or watch it replayed again may have some of those kind of, I guess, post-traumatic kind of feelings that come to the fore.
Powerful. One of the things that was really clear for me as I was listening, and I've listened to these stories now, many, many, many times, no matter how many times I hear them, they take me right back to May of 2020. They take me back to the aftermath of the murder of George Floyd. You hear pain and terror and rage and fear, courage. You hear all of these emotions, and for me, I want a healthcare system that becomes in tune to the emotional lives of Black nurses, of Black healthcare workers, so that they understand this is not a world of professions. It is a world filled with people navigating impossible realities in order to do the very best that they can. And there's no way to continue that outside of a different kind of support. And that part of what came up again and again was how much or how little the institution of healthcare cared about the lives and the well-being of the Black healthcare workers, the Black nurses that put their lives on the front line. So I wonder for you, Abigail, if you could take us back. I mean, you were really instructive in the recruitment gathering and some of the real challenges that we faced at the beginning. And I wonder if you could talk a bit about the experience of gathering stories and the kind of research that was done and the kind of approach that you took and that I joined you with.
Okay, well, the approach that I took was, my vision was to have a regional approach. I didn't want to just have it as a London-centric, conducting interviews with people just in one city. I wanted it to have their voices represented up and down the country. And so in doing that, I approached organisations regionally, promoted the project on community radio stations in respective cities, in London, outside of London, and individuals as well, who, and also some people actually put forward names. So, equality and diversity managers, or that kind of thing, or business networks. Sometimes not even necessarily healthcare, just Black network groups. And within those Black network groups, they might be doctors and nurses who are members. So it was just to spread the word really of the project and, for people to come forward and feel comfortable to do so. So it wasn't just medical.
I think that's really important that the breadth of the net that you cast in order to bring the world of healthcare to the table. All these different African Caribbean associations, organizations, Black professional networks, bringing them together because of course as communities we have a lot of healthcare within our families, and engaging people that way, which is very distinct and different than the US recruitment approach, which was much more online, social media, LinkedIn, WhatsApp, and Dr. Gallen, who was the director of the US, using that connection to engage. And I think it's a really important thing to recognize, that just as there's different kinds of Blackness within one pandemic, and so we also need to reflect and understand we need different kinds of healing as a result of that. Carol, you were really instrumental in contextualizing the world of healthcare, race, and Britain. And it was the year of the nurse in 2020. What a time to have the year of the nurse. I wonder if you could just talk a bit about that and the importance of context for the project.
It all happened at a very crucial time. I think it was the year of the nurse. It was a time when the NHS was about to celebrate nursing, as was the world, but also a time when we were also embarking on, international recruitment in a mass way, in a bigger way than we have for a long time. It was also probably about 4 or 5 years since we've had the Workforce Race Equality Standard, annually churning up the same data and telling us about the disadvantage and the deprivation yet again. And a time when perhaps there's a little bit of apathy set in, because the conversation about race in particular and of all the protected characteristics, there is a dislocation between conversation and action with regard to race that I think is broader than many other areas. There isn't the levels of empathy that we require in the seats of power where decisions are made to be able to connect the conversations with the actions. And in the middle, there is this, I don't know what to do. Yes, I don't know what to do. And it's one of the only areas, I think, that as a senior person you can get away with saying, look, I don't know what to do on an annual basis. And also get away with a lack of progress. So all of those things collided, and what it brought to the surface was a lot of fear. And I remember right at the start of that pandemic, I was hearing from nurses, Black nurses, global majority nurses, that they were at more risk, that they were being put on COVID wards, that, all sorts of things were going on. I am a nurse, but I don't work as a nurse. So there's a little bit of distance. And my position affords me the opportunity to raise some of these kind of issues. And I did. I raised it as an issue. I also tried to get hold of data and said, Public Health England, where's the data? Thought they collected ethnicity data because I have a public health background and we used to. But there was no data. And I was really surprised that Public Health England were no longer collecting ethnicity data. I was becoming more and more frightening because I was hearing of more and more people dying. And I thought there's got to be something here that we're missing. And as I raised it, and I have to say, and this is important because I think the challenge you have in terms of recruiting people to tell their stories is largely because of the way racism is embedded into our institutions and our cultures. And so there is a silencing, there is a covertness associated with racism in the UK. And so by raising these issues, I attracted quite an enormous amount of negativity. It lasted for a couple of days with most people, and then it flattened out because there were some GPs who also were looking at the data and thinking there's something wrong here. what they did was look at ICU data. And the ICU data did have the ethnicity attached to it and demonstrated quite clearly that there was a disparity in terms of outcomes and race. And so therefore the issues I raised were pertinent, were justified, and then we had something of a huge response to that around the country. But I have to say, in that gap, I experienced what I guess everybody experienced when they made the decision to tell their story. Because it's lonely out there, there's no cover, there is no protection, it's hostile, it's venomous, it's wicked. And it's hard to prove it sometimes. Sometimes it became very overt. There were certainly times when, I approached my car and the window wipers were raised and all sorts of things, as if I had to walk around my car on occasions to make sure that everything was all right because of the response, the venomous response that I received by even suggesting that there may be a disparity. And when people speak, there is no protection. If there's no protection, there's certainly going to be no focus on healing. And so those things, the protection, the prevention, and the promotion are really important, which is why one of the things I called for was a public health approach to racism, which includes that recognition that people have experienced deep trauma and need a response which is equal and opposite to ensure that they heal.
Oof, that's so powerful. Part of what's so powerful about that is that the venom is directed at the raising of the issue as opposed to the reality of the issue. Because it's the reality of the issue that is causing the devastation. And the UK is Olympic level skilled at silencing the reality and punishing what they perceive to be the reactionary. And by that I mean the person articulating, in this case you, what is going on, is treated as if they themselves are the racism venom that needs to be exorcised out of the industry. And let's talk a bit about silence and the way it works both within the institution and also how it shaped the project. I think something we learned very early is silence is both weapon and shield. Sometimes people are staying silent literally as cover, and silencing is used to create the illusion of inclusion, the illusion of support. And the importance of these stories was saying you can never again say about COVID that you did not know, because there's 300 plus stories strong. And I think that section on systemic racism, the common threads through that highlight how you have both the specificity of the UK and the connectivity of how racism wounds and how those wounds go deep and the failure to really reckon with them. So, Abigail, I wonder if you can talk a bit about how silence shaped the recruitment gathering space and the approach to kind of navigating that.
Well, for me, I mean, I understood both sides. I understood, first of all, that the people that were, the nurses and doctors that were giving up their time to speak to me were discussing a subject matter that, for the first time, really, I think the vast majority outside of their family and friend circle. So, first of all, they're revisiting, they're processing a traumatic time currently, and they're speaking to a stranger about it outside of their family and friend circle. So I totally understood that and respected that. On the other end, I understood totally that there were people that didn't want to go there, didn't want to engage with the project because they were rehashing a situation that they were in turn processing and dealing with, and they didn't want to revisit it again. They were going through their own coping mechanism. I respect that and understood both sides of the coin. In relation to the recruitment, it was that. It was I will have to speak to my department about speaking to you about this subject matter. And there were others who were going through certain situations within their workplace, but we omitted that and also told me certain things in confidence off the record that they couldn't discuss within that context of that interview. So I understood that, and I was grateful for them for their sharing those stories to me, and also feeling that comfortable enough to actually tell me that. That was what it was. It was just, this is my employer. This is what I have to do. This is where my income is. I can't go any further on that. And I totally respect that.
Carol, I wonder if you could talk a bit more about what I call sector silence and institutional silence, and how that really helps entrench the status quo and prevents the kind of recognition of, for example, racism as a public health issue. An advance that we've seen, for example, in the United States, where it was literally declared as a public health crisis as a way to move forward. How does the silencing and the erasure, the silencing, the omission, the erasure, the flattening, how does it protect the status quo and support the illusion of engagement, but the reality of an entrenched kind of stillness? Nothing's moving.
There are winners and losers, and I think that's the challenge. The leadership of the NHS is still, by and large, overwhelmingly white, and so people won't have the lived experience of what it is to be from the global majority and all that comes with that, or to be black within that, because there are different experiences that we have under that global majority umbrella and under that black umbrella, because we're coming from different places, and there has been layering. I come from I'm a descendant of a slave, and I was raised in the UK in the 70s and 80s, where racism was very covert, in your face. People would disappear into police stations and come out with damage, yes? And there was nowhere to take that, and you were never believed. That may be different from somebody who has been internationally recruited and come here in recent times with hopes, yes, of British nursing, and I'm got a wonderful career ahead of me, and then becoming cognizant of something else that's going on that they're not quite sure of, because when you're born in a country where you are the majority, you may not have come across racism in the way that it manifests itself here, and it's very covert. The structure enables a silencing and a lack of action, because we're in a kind of a denial, and there's layers to this denial. Some people may say, yes, racism is real, we need to tackle it, etc., etc. It depends on the location of the racism. If the racism is somebody else, and I'm saying, you're racist, then that's okay. But actually, if the racism is located within my sphere of influence or with me, then I'm defending. And so it's that reflex action of the need to defend myself first and foremost that supports the ongoing silencing. So there's almost an unspoken rule that first of all we protect ourselves. And when the word racism comes up, perhaps the first thought is, I need to protect myself. When we move from I need to protect myself to wanting to protect the individual who's experienced the racism, we will have made progress. But this is so deeply entrenched that if you were to look at reviews of things that have happened to not just nurses but staff in the NHS in institutions like the Royal College even when race plays a clear part, the reluctance to really delve into race and name it as a factor is very, very powerful. There is a denial, an institutional denial that is so deeply entrenched, nobody wants to own it when it's within their own circle. And that's a deeply entrenched unspoken rule within the UK and its institutions.
Let's talk a bit about the power of the Black Frontline as a project and your hopes of how it contributes to a healing for Black healthcare workers, but also healthcare in the future. I mean, Abigail, for you having walked through and worked with and spoken with, I mean, quite literally hundreds of people, what is your thought around that? And as we're speaking, we want to encourage folks to use the chat if you're online and you have comments or questions, and I think there'll be a mic going around very soon so that folks can also have questions answered or comments made.
Well, one of the reasons why I wanted to jump on this project was I worked on a book called Many Rivers to Cross and collected stories. This was exclusively with Black Caribbean doctors and nurses, allied professionals, 1948 to 69, the 21st anniversary of NHS, and that was way back in 2005. And part of those stories, they discussed to me their experiences as Black healthcare workers working during that time. I'm sad to say that there were some experiences of interviews, stories that I was told with the Black Frontline that were mirrored the experiences of the people that I interviewed who worked in the NHS between 1948 and 1969. And I came as an approach to see if there was any connections and was hopeful that, well, being optimistic, let's put it that way, that things had moved on, but it was the same situation but slightly different because of the time period, the way people spoke to you, certain situations that you observed things, as you've mentioned, being a bit more covert, I guess, rather than overt in relation to what you said or, well, sometimes what you didn't say to that person, how you made that person feel. So I just wanted to say that I wish I could be on this platform and say, be positive. I would like to be, but there were some connections there in relation to their stories, very similar circumstances, but in different ways.
Right. Can you identify some of those connections?
For example, if I spoke to a nurse from Barbados back in from that book, who had a bucket of water chucked over him when he was sheltering outside someone's home. That wasn't in the medical situation, but that was just the general where somebody, a form of racial discrimination against him. So fast forward to Black Frontline, I spoke to a nurse who noticed more racism because she was in a different environment. She wasn't in her normal ward. She was outside of her ward, and it seemed that all the negativity she noticed more because they were in a smaller space. So she noticed and brought up as a complaint that she felt that her white colleagues were getting longer lunch breaks than the Black colleagues. And she actually called it segregation. That was her word. She felt she was working under segregated working conditions. And I had to wonder, as I said, in a historical perspective, that black male nurse from Barbados who had a bucket of water chucked over his head for sheltering under someone's house. And then this nurse in 2021, 2022, an experienced nurse who worked, diligently in her job for many years, felt totally disrespected in relation to that, just that example. So I think there's choppy waters ahead and there's improvements to be made. I think I'll just
say that. Your thoughts, Karen?
I think we have to keep hope alive for our sanity and for our healing. I think the things that gave me hope was that there was a rapid response once it was clear that there was an unequal impact. Certainly from a nursing perspective, there was a national consultation that very quickly took place. There were risk assessments that were put in place across the country, which gave people options so that some protection could have been available to them. I was cognizant of the impact of years of racism on some people because I had conversations with people who were going back to work. Even when I was telling them the risk assessment, you fit the criteria. And they were saying, no, my manager said. And such was the fear, such was the power that was given to their immediate work environment, their immediate managers, that they were still willing to risk their lives. And these were people who had relatives who died of COVID. So they were very clear about what the consequences could be. And they had health issues themselves. But they still felt compelled to go because they felt so unprotected. So that safety factor is vital going forward. I think we have made some inroads, and I can see how these experiences can now contribute to the next stage of the journey. Some of the progress that we've made, there is a national ethnic minority action plan. And since in the last few years, the last couple of years, I have to say that Ruth May as a chief nurse has probably made more progress than any other chief nurse in that there are more chief nurses now from the global majority than there ever has been. It always bobbed around 10 to maximum of 15. That's increased about 300%, in the last couple of years. And that's as a direct result of that consultation, of that ethnic minority action plan, and prioritising race equity within that. I think the other thing that gives us hope is the anti-racism work that has taken place, which has been done jointly between the Royal College of Nursing, the NHS Confederation and the Chief Nurse Office, which actually links anti-racism into the Code of Conduct for nurses in a way that leaves no hiding place, and that will mean that no nurse, and if no nurse, then no other healthcare professional, can actually at any point in the future deny their role and be unclear about their responsibility as a nurse, as a healthcare professional, when it comes to anti-racism. And anti-racism is just not being racist. It's about actively working to end racism, yes? And so if we are not doing anything tangible to address racism, then we're racist, yes? So we have to do something to be anti-racist. So I think the experiences, and I don't think people recognise the cost. There is a price to pay for opening your wounds and telling your truth, and then you walk away and there's nothing. You go round the corner and somebody still calls you a black expletive, or you're still denied your rights, or you're still not given the job that you know that you deserve and you're way overqualified for, or you're still excluded from those meetings. You're still shut out from opportunities. So for me, these experiences are priceless, and we need to value them accordingly. And valuing them means embracing them, understanding them to the point that we're moved. Our empathy moves us to action. If there is no action, then we're saying that they have no value.
Definitely for us, empathy, equity, and emotional justice. Without stories, minus strategy or systemic change, create and entrench the kind of cycle of ongoing, what I said at the beginning, the carelessness of people's experiences, just being used to regurgitate but entrench the status quo.